Вот кнопочка.
Ага.
Пожалуйста.
Меня слышно, да? Мгм. Здравствуйте. Good afternoon. Will you sign your presence, please? Good afternoon, please. It's time to start my lecture. I don't see any students. Where are you? Now, today, right now, we have to start the lecture and to discuss very important topic. Is devoted to management of a patient with arterial hypertension in endocrinology practice, and some information about a patient with metabolic syndrome, what's about the approach to this patient, etc., in very short words. Now, I see only one student, Miss Need here. Good afternoon. Where are the rest students? I'd like to tell you that your marks will depend on your presence at my lecture. It's important to be here today. The definition of arterial hypertension is well known for everybody. In 1999, the experts of the World Health Organization discussed this problem, and they defined arterial hypertension as a clinical syndrome of constantly increased systolic and diastolic blood pressure. Значит, criteria of increase of systolic blood pressure if systolic blood pressure is equal or more than 140 millimeter mercury, and criteria of increase of diastolic blood pressure are the following: if BP blood pressure is more than 90 or equal to 90 millimeter mercury. And let us revise information about classification of arterial hypertension according its etiology. They divide primary or essential arterial hypertension. In Russia, in Ukraine, this disease was named, and it's still named even nowadays, as hypertonic disease. Hypertonic disease is equal to primary or essential arterial hypertension. But what is primary or essential arterial hypertension like? It's a disease, it's a disorder, it's a clinical syndrome that includes hypertension of unknown cause, unknown etiology. And they divide also secondary or symptomatic arterial hypertension. Symptomatic arterial hypertension is a hypertension, the cause of which can be revealed. Therefore, this is a syndrome of the underlying primary disease. And is this problem so significant to discuss it once more? I hope that you remember that in the 20th century, arterial hypertension and atherosclerosis and the diseases, those were associated with atherosclerosis and arterial hypertension, were named as silent killers. Nowadays, I think that this situation is still present. Arterial hypertension is still silent killer of the 21st century as well. And it's one of the major cardiovascular risk factors that directly contributes to acute myocardial infarction, chronic heart failure, cerebrovascular accidents, peripheral arterial insufficiency, and premature mortality in many countries all over the world. What about distribution of arterial hypertension, including symptomatic arterial hypertension. In other words, it's named as epidemiology. We know that increase of distribution of arterial hypertension is more than twice in comparison with 1998 year. The patients' number with arterial hypertension, for example, in Russia, is more than 41.6 million people, approximately 42 million people, maybe more than 42 million people in real practice. And it corresponds to about 30%, approximately 30% of the whole population. And diseases of cardiovascular system constitute about 56%, approximately 60%, in a structure of total mortality causes. And the major complications of arterial hypertension are the following. Ischemic heart disease constitutes about 47%, cerebrovascular diseases 38%. So I think that it's very clear that arterial hypertension is a widespread disease, and it's very significant as a high risk of mortality because of cardiovascular diseases all over the world. And what organs are affected in the patients with arterial hypertension? Such organs are named as target organs. Are they significant organs? Are they significant systems? Now let us read central nervous system. What about the damage of CNS? Strokes. Strokes occur in 7 to 10 times more frequently than in population. And you should remember that strokes lead to, they are complicated by invalidization of the patients, and mortality is very high, even nowadays. And what about heart, myocardium, heart? Is it affected? Yes, of course, because it's well known, it was detected, it was determined that acute myocardial infarction occurs in 4 to 5 times more frequently. What about eyes? Exudates associated with retinal ischemia or infarction, they occur also more frequently in the patients with arterial hypertension than in population. Kidneys are affected, proteinuria and progressive renal failure that leads to chronic renal failure, and such patients, they also need such treatment as hemodialysis, peritoneal dialysis, transplantation of kidney, and it can be also become a cause of the death of the patient. And peripheral arteries can be also affected because of aortosclerosis, aneurysms, and of course atherosclerosis occurs more frequently in the patients with arterial hypertension. What about any other risks of arterial hypertension in the population? We know about significance of age. If age is more than 60 years, it's assessed as a risk factor of arterial hypertension, of course. Males experience arterial hypertension more frequently and earlier than females. And what about females? When females becomes elder, menopause and after menopause, postmenopausal women, they also have a high risk to experience arterial hypertension. Family history of cardiovascular disease, it's important, of course. Tobacco smoking, high cholesterol diet, coexisting disorders such as diabetes, obesity, and hyperlipidemia, and high intake of alcohol, sedentary lifestyle, and something else. And I'm sure that you remember about the existence of pressure and depressor mechanism of blood pressure regulation. Let us revise them. You can see natriuretic peptides, they're divided to right atrial peptide, cerebral peptide, C-peptide, the next kallikrein-kinin system, nitrogen, oxygen, prostaglandins I2, E2, histamine, acetylcholine, adrenomedulin, and insulin. Such factors, they experience depressor mechanisms, but there are also pressor mechanisms. They are very important to know them. I'm sure that each medical student, each doctor, of course, know about renin-angiotensin-aldosterone system, RAAS, sympathetic adrenal system, endothelin, neuropeptide gamma, thromboxane, A2, sodium pump inhibitors, arginine, vasopressin. And normally in the healthy individuals, it should be balanced between pressor and depressor mechanism. But if the patient experiences constant arterial hypertension, of course, you should understand that pressor mechanisms, they are prevalent over depressor factors. Now you can see a photo, a picture, and it's illustration of renin-angiotensin-aldosterone system. I'm sure that everything is very clear on this picture. And what about structure of arterial hypertension diagnosis? Arterial hypertension is divided to primary, you remember, and secondary. What else should be also noticed in the diagnosis? Degree of arterial hypertension according to blood pressure level. We have also write about a stage. A stage depends on impairment of target organs. And what else is also of great importance, to write about stratification of risk for individual. Now you can see classification of arterial hypertension according to the blood pressure level. And there are different categories. You can see 3 categories for normal blood pressure, optimal blood pressure for systolic BP is less than 120 millimeter mercury. For diastolic blood pressure, it's less than 80 millimeter mercury. Normal but high normal blood pressure for systolic BP is less than 130. Diastolic BP should be less than 85. And and high normal is also from 130 up to 139, and diastolic from 85 up to 89. Arterial hypertension was divided also to 3 grades. The first grade with systolic blood pressure 140 up to 159 millimeter mercury. In the past, it was named as a mild arterial hypertension. Nowadays, this term is not so popular. You should know why. And diastolic blood pressure is from 90 up to 99. And the first grade of arterial hypertension is characterized by moderate arterial hypertension, and systolic blood pressure is from 160 to 179. Diastolic blood pressure 100 to 109. And the third grade, severe arterial hypertension, systolic blood pressure is more than 180, and diastolic blood pressure, when diastolic blood pressure is more than 110 millimeter mercury. And classification of arterial hypertension according to the stages. The first stage is characterized by the absence of objective signs of target organs affection. Arterial hypertension is present. It's not very high, but it's present. It can become persistent, but commonly it's rather transient. The second stage, or the second degree of arterial hypertension, there are objective signs of target organs affection, but without its prominent dysfunction. For example, you can detect left ventricle hypertrophy on the ECG, on the echocardiogram, on the X-ray gram of heart shadow, or you can detect generalized narrowing of arteries of the retina, and you can detect also the signs of affection of kidneys, such as microalbuminuria or proteinuria, or increased creatinine in plasma. And the third stage or the third degree of arterial hypertension, usually it's named in our country as the third stage of hypertonic disease here. There are objective signs of target organs affection with its dysfunction. You can detect symptoms and signs of a stroke, or maybe the patient has experienced stroke in anamnesis. There are symptoms and signs of hypertensive encephalopathy, hemorrhage in the retina, and symptoms and signs of renal failure, etc. And now you can see also one table. It's very important also to know how to do stratification of risk to quantify prognosis for this concrete patient. What should be known about the patient? Degree of hypertension in millimeter mercury, 3 grades you can see. And what else is also of great importance? The presence of risk factors and disease, history disease. And depending to the presence of the degree of hypertension, the presence of risk factors, risk can be from low, medium, high risk, very high risk. I'd like to pay your attention and remind you that if there is diabetes mellitus, risk factor of cardiovascular events and diseases that can lead to mortality of the patient or lethality of the patient should be assessed as high risk or very high risk. It's very important to understand. And how to make diagnosis. You can see one example of diagnosis. The patient has been suffering from essential hypertension. Of course, if you live in Russia or Ukraine, you should write hypertonic disease. Abroad, this disease is named as essential hypertension. Essential hypertension or the third stage, the second degree, very high cardiovascular risk, hypertensive heart failure, chronic heart failure, or the second stage with systolic dysfunction. And there is the third functional class. No, there is one small mistake, because the author forgot to write about the disease, the cause of the third stage. I think that something has happened to this patient. Maybe the patient has had myocardial infarction in his anamnesis, maybe stroke. In this case, we have to write about it. So, myocardial infarction, for example, in 2018, or maybe in April of 2018. It's better also to give characteristics of myocardial infarction. The same is about stroke, etc. And you can see diagnosis of symptomatic arterial hypertension. You can see the example of the patient who has been suffering from aldosteroma Aldosterone, the right adrenal gland. Of course, you should confirm the location of aldosterone. Cone syndrome includes secondary arterial hypertension of the second stage, the first degree, and moderate cardiovascular risk. Heart failure, of course, heart failure in this case, chronic heart failure, the first stage. Now, I hope that my explanation was clear for everybody. And it's very important to remember how to measure, how to take blood pressure, how to measure it correctly. It's very important because mistakes can be the cause of inadequate treatment, etc. Of course, a device or machine should be validated, well maintained, and properly calibrated. It's very important to remember. And you can measure blood pressure sitting routinely with additional standing blood pressure in elderly and diabetics. You should remember that in diabetic patients and elderly patients, orthostatic hypertension can be present. And some other very important rules. We have to follow all these rules not to become mistaken. Now let us revise classification of secondary arterial hypertension. I think that everything is very clear, and the first group of causes of secondary arterial hypertension are associated with kidney problems, renal problems. They can be renal parenchymal disorders, renovascular disorders, etc. Some other, and endocrine diseases. Which endocrine diseases can be manifested by arterial hypertension apart from diabetes mellitus? Of course, it's better to start with diabetes mellitus. Diabetes mellitus because the patients with diabetes mellitus, they experience parenchymal and renovascular disorders. But what about any other diseases? And you can see that the list of such diseases is rather long. Cushing's syndrome and Cushing's disease, primary aldosteronism, pheochromocytoma, primary hypothyroidism, hyperthyroidism, acromegaly, hyperparathyroidism, and all above mentioned diseases they can be manifested by arterial hypertension. And arterial hypertension in these cases should be assessed as secondary or symptomatic. And the main disease is different, maybe aldosteronism or pheochromocytoma, etc., etc. And there are different other different causes of secondary arterial hypertension. You can see neurogenic causes in increased intracranial pressure because of tumors, inflammatory diseases, hypothalamic syndrome, and the group of cardiovascular hemodynamic causes. They are the following: coarctation of aorta, patent ductus arteriosus, atherosclerosis of aorta, insufficiency of aortic valve, complete AV block, congestive chronic heart failure, polycythemia, and all above mentioned disorders, they are manifested by arterial hypertension, also secondary, and iatrogenic arterial hypertension because of the administration and intake usage of different medications. First of all, corticosteroids, thyroxine, thyroid hormone preparations, especially in high dosages, oral contraceptives, especially the first generations. Oral contraceptives, those contain estrogens. Sympathomimetics, for example, salbutamol, phenaterol, anabolic steroids, non-steroidal anti-inflammatory drugs, carbenoxolone. No, you can see a table with a list of risk factors for cardiovascular diseases. And the first position is for the most significant risk factor, and this factor is named as arterial hypertension. The next age, more than 55 years for males, more than 65 years for females, no, and approximately more than 60 years for population. Tobacco smoking, dyslipidemia is of great importance. You remember about hypercholesterolemia, more than 5.2 millimole per liter, increase of lipoprotein low density cholesterol more than 2.6 millimole per liter, increase of level of high density, I'm sorry, not increase, but decrease of level of high density lipoprotein, cholesterol less than 1.0 millimole per liter for males, less than 1.2 millimole per liter for females, triglycerides concentration or level if it's more than 1.7 millimole per liter. In total, such disorders of lipid metabolism they are named as dyslipidemia. Dyslipidemia is characteristic for atherosclerosis, for the diseases those are associated with atherosclerosis. First of all, ischemic heart disease, atherosclerotic changes of peripheral arteries, and I'd like to pay attention that there is so-called metabolic syndrome, and for metabolic syndrome, arterial hypertension is characteristic, dyslipidemia is characteristic. Of course, we know that age is also of great importance. In elderly people, metabolic syndrome occurs more frequently than in young. And abdominal obesity is also characteristic for metabolic syndrome. It's also a risk factor for cardiovascular disease. Abdominal obesity should be detected according body mass index. You should remember how to calculate body mass index. You should take body weight in kilogram, divided it to height in meter square. And if your result is in the range from 18 up to 24, 25, it should be assessed as normal BMI. It's normal BMI. If it's more than 25 up to 29.9, it corresponds to overweight of the patient, or the weight of this individual. And if it's more than 30, from 30 to 34.9, it's assessed as criteria of obesity of the first degree. 35 up to 39.9 corresponds to obesity of the second degree, etc. What else is also of great importance? We also have to assess the configuration of body of our patient, because BMI can be increased not only because of obesity, but also because of increase of skeletal muscle mass. For example, in sportsmen, in people, they are not sportsmen, but they're going for sport, physical culture, etc. You should also remember about it. Which value is also very important to have. We have to detect the waist circumference, and if waist circumference for female, if it's not more than 94 centimeters, it's normal. For male, or I'm sorry, for female, not more than 80 centimeters, for males, not more than 94 centimeters. And you can see slightly different criteria for abdominal obesity. Such criteria are used prevalently in the American medical literature. You can see if the waist circumference is more than 102 centimeters for males, it's a sign of abdominal obesity. For females, if it's more than 82 centimeter. 82 centimeter. And yes, there is not very significant difference between different references. And what else is also important as a risk factor for cardiovascular disease? Family history. What should you ask a patient about? About the health of the patient's parents, grandparents, about the age when his relatives died because of myocardial infarction or maybe stroke, etc. If age was rather young, it should be assessed as a risk factor for this individual. Fasting hyperglycemia. If fasting hyperglycemia is from 5.6 to 6.9 millimole per liter, it's also, you should remember that it's such data, such value is characteristic for glucose intolerance. Such variant of glucose intolerance is named as fasting imperative glycemia. And fasting imperative glycemia is assessed also as a risk factor for cardiovascular disease. And at the same time, it's also assessed as a component of metabolic syndrome. Diabetes mellitus, especially diabetes mellitus type 2. No, diabetes mellitus type 1 is also a risk factor for cardiovascular diseases. And diabetes mellitus type 2. I think that this information was clear for everybody, and let us continue. Another table about stratification of risk factors. And now let us discuss interactions between diabetes mellitus and arterial hypertension. First of all, I want to remind you the definition of diabetes mellitus. Diabetes mellitus, you should remember that it's defined as a group of metabolic diseases characterized by chronic hyperglycemia. Chronic hyperglycemia, it's a clinical syndrome. You can say characterized by a clinical syndrome of chronic hyperglycemia because of defects of insulin secretion, insulin action, and combined influence of these factors. You remember that there are 4 types of diabetes mellitus, and the most widespread type is diabetes mellitus type 2. The most of patients, diabetic patients, they suffer from the second type of diabetes mellitus, and relative insulin deficiency is characterized for the second type, and absolute insulin deficiency that occurs because of autoimmune insulitis and provoked by viral infection and caused by hereditary factors, genetic factors. Absolute insulin deficiency is characterized for the first type of diabetes mellitus. And diagnostic criteria of diabetes mellitus should be well known for everybody. No, you can have a look to this table, please. You're welcome. You're welcome. It's obligatory to know, to remember. And another diagnostic criteria of diabetes mellitus, not only fasting glycemia in capillary blood or venous plasma, and intra-hours after oral tolerance test, and maybe it can be a random measurement, you should remember. And what else is also very significant to detect glycated or glycosylated hemoglobin. If it's more than 6.5%, it's assessed as diagnostic criteria of diabetes mellitus. Diagnosis of DM is made if there is a presence of 2 values: increased glycated hemoglobin detected once, and another result of increased value of glycated hemoglobin on different dates. And another variant, if you have detected increased of glycated or glycosylated hemoglobin. No, I hope that you remember that HbA1c stands for glycosylated hemoglobin. A1c is a fraction of hemoglobin that is binding to derivatives of glucose. And if there is a combination of the increased concentration of glycated hemoglobin and increase of glucose concentration, hyperglycemia in other words, it also can be used as criteria of diabetes mellitus. So you can make such diagnosis. You can confirm diagnosis of DM. The next, chronic complications of diabetes mellitus. I hope that everybody knows that they are micro and macroangiopathy. Microangiopathy manifestations and locations are different, and the most important location for arterial hypertension for diabetes patients are nephropathy, kidneys, nephropathy. Efferent and efferent arterioles can be affected because of the toxic influence of glucose. And the result is diabetic nephropathy. Diabetic nephropathy outcome is chronic renal failure, and of course it should be manifested by arterial hypertension. Of course, arterial hypertension is secondary, symptomatic. And what's happened to kidneys? Nephrosclerosis occurs in kidney. What else is also characteristic for diabetes mellitus? Macroangiopathy. And the most important in this case is ischemic heart disease and atherosclerosis of aorta. damage of arteries of muscle type arteries, muscular type arteries, aorta leads to the increase of peripheral resistance. And it's also one of the way of pathogenesis of arterial hypertension. And what else is also important to remember about cerebrovascular disorders? Peripheral neuropathy, syndrome of diabetic foot, autonomous neuropathy, but for arterial hypertension, of course, the most significant nephropathy and ischemic heart disease, atherosclerotic damage of aorta, and cerebrovascular disorders. And what about methods of investigation of the patient suffering from diabetes mellitus and arterial hypertension? What methods and tests are obligatory? No, of course, we have to start with clinical examination. It's a rule. We have to interrogate the patient. We have to know the patient's complaints. We should ask about the present history, the past history, and to analyze the patient's answers and to do the proper conclusions. And what's about methods of investigation? You can see CBC, complete blood count. Yes, it's obligatory, it's important. Urinalysis, what can you detect in urinalysis? Glucosuria can be detected. Maybe acetonuria, your patient suffers from diabetes mellitus type 1, and if there is ketoacidosis. Microalbuminuria, it's a special test. We should take daily diuresis or maybe morning. Another variant of this test is morning sample of urine, and albumin concentration should be detected. And total protein is important to detect. Total cholesterol, LDL cholesterol, HDL cholesterol, we have discussed it already. Triglycerides is important. And transaminases, alanine transaminase, asparagine transaminase, they characterize, their level characterize the hepatic function, the liver function. And urea, creatinine, you should remember that creatinine is very important to characterize protein or nitrogen metabolism, and it's very important for calculation of glomerular filtration rate. Electrolytes, potassium, sodium, GFR, again, yes, glomerular filtration rate. Blood pressure should be controlled not less than thrice a day. Instrumental methods, what are they? ECG is obligatory. The chest X-ray gram is obligatory. If there are indications, but usually there are such indications, echocardiography should be used in the examination of the patient. And whose consultations can be helpful? Consultations of ophthalmologist, angiosurgeon, neurologist, for females, of course, gynecologist consultation. And you did not see such tests as glycemia. It's obligatory. Fasting glycemia, postprandial glycemia, and of course glycated hemoglobin. It's obligatory biochemical test. I think that you understood me. And pathogenesis of arterial hypertension in diabetes. In patients with diabetes mellitus type 1, arterial hypertension develops secondary because of diabetic nephropathy. Diabetic nephropathy is the most significant cause of arterial hypertension in such patients. In 80% patients with diabetes mellitus type 2, essential arterial hypertension commonly precedes development of diabetes mellitus. So firstly, essential arterial hypertension, diabetes mellitus type 2, and combination will lead to the worsening of the patient condition. And what else is also important to know? Disturbance of circadian rhythms of arterial blood pressure is very characteristic. Its decrease at night is weakened and orthostatic hypertension occurs. Diabetic nephropathy. Some words about such complication of diabetes. It's a specific bilateral injury of kidneys accompanied by formation of nodular or diffuse glomerular sclerosis, resulted in terminal chronic renal failure. And diabetic nephropathy occurs in 6 up to 60% patients with diabetes mellitus type 1 in 5 to 15 years after its manifestation, and in 4 up to 30% patients with diabetes mellitus type 2. Pathogenesis of arterial hypertension and diabetic nephropathy is the following. First of all, initially non-enzyme glycosylation of proteins occurs in renal membranes. Non-enzyme glycosylation because of the presence of chronic hyperglycemia. And we should remember about direct glucose toxic influence, activation of protein kinase C, activation of production of free radicals, and disturbance of synthesis of the most significant structural glycosaminoglycan of glomerular membrane of kidney. Such substances, heparin sulfate, leads to damage of basal membrane of nephrons in the patient's kidneys, in both the patient's kidneys, and to development of microalbuminuria and later proteinuria. So disturbance of synthesis of glycosaminoglycan of glomerular membrane of kidney, heparin sulfate. Please remember, you can use this information in your answer to your exam. And pathogenesis of arterial hypertension and diabetic nephropathy is also associated with the occurrence of intraglomerular hypertension, because this factor is the main hemodynamic factor of occurrence and progressing diabetic nephropathy with manifestations of hyperfiltration at its early stages, and long-term mechanical irritation of glomerular structures leads to collagen hyperproduction and its accumulation in mesangium. And this is the initial stage of nephrosclerosis. And there is a super high activity of local renin angiotensin aldosterone system, not P but renin angiotensin aldosterone system. You should know that there is systemic renin aldosterone in angiotensin aldosterone system, and there is also local RAAS. They're different, and diagnostics of diabetic nephropathy is very clear. It's important to check a daily diuresis, Zimnisky test. Zimnisky test, no, I hope that you know what is Zimnisky test like. So we have to assess a concentrative function of the patient's kidney, and of course we have to detect, of course, filtration, glomerular filtration in our kidney. What tests are also very beneficial, they are necessary. Microalbuminuria test. Criteria for microalbuminuria are following. If albumin concentration is from 30 to 300 milligram per 24 hours, or 20 to 200 microgram per minute, it's a criteria of microalbuminuria. Is it understandable? If you have studied endocrinology this year, this semester, you should remember that since the stage, microalbuminuria stage, indications for insulin therapy occur in the patients of diabetes mellitus. You should remember, if the patient suffers from diabetes, there is diabetic nephropathy, and if there is microalbuminuria, you have to administer insulin treatment, insulin therapy. The next, proteinuria. Yes, proteinuria can be detected. What about criteria of proteinuria? If the level of protein in the daily diuresis is more than 300 milligram, it's a sign of proteinuria. Proteinuria can become massive, more than 3.5 gram in urine, and in this case, such proteinuria indicates to nephrotic syndrome. Glomerular filtration rate should be calculated. What about the normal values for GFR for male? They are from 100 up to 150 milliliter per minute, and for female from 85 up to 130 milliliter per minute. And pathogenesis of arterial hypertension in diabetic patients, diabetic macroangiopathy is also of great importance, ischemic heart disease, chronic heart failure, cerebrovascular diseases, chronic obliterate diseases of the lower extremities, and some other factors such as chronic hyperglycemia, glucose toxicity, oxidative stress, the activation of protein kinase C, endothelial dysfunction, dysfunction of sarcoplasmatic reticulum, mitochondrial dysfunction, disturbance of calcium homeostasis, activation of renin angiotensin aldosterone system, rigidity of vessels, increase of peripheral resistance because and disturbance of copper metabolism, dyslipidemia. No, you can see that such disorders as arterial hypertension, ischemic heart disease, diabetic cardiomyopathy, chronic renal failure. They are of great importance for occurrence of increase of mortality because of cardiovascular diseases. But if there is diabetes mellitus in the patient, cardiovascular risk in such patient with arterial hypertension or maybe ischemic heart disease becomes high at the third risk factor, the third degree of risk, or very high, the fourth. If ischemic heart disease is present in the patient, we should write very high risk. If there are no symptoms and signs of ischemic heart disease, but if there is diabetes mellitus, risk should be assessed as high. It's named also risk number three, or the third degree of severity. Therapeutic purposes in diabetes mellitus. What about our purposes when you manage the patients with diabetes mellitus? First of all, it should be control of carbohydrate metabolism, control of lipid metabolism. Total cholesterol should be less than 4.5 millimole per liter. I'd like to pay your attention that it should be less than 4.5 millimole per liter. For population, it's enough to have total cholesterol less than 5.17 millimole per liter. But if your patient suffers from diabetes, such criteria becomes more strict. And the concentration of cholesterol in lipoprotein of low density should be less than 2.5 millimole per liter. And if there are cardiovascular disease or chronic renal disease of 3 degree or more, concentration of cholesterol in lipoprotein of low density should be less than 1.8 millimole per liter. In lipoprotein of high density should be more than 1.0 for males and more than 1.2 millimole per liter in females. And triglycerides concentration should be less than 1.7 millimole per liter. I want everybody to have this information because when at the exam a lecturer will ask you about the purposes of treatment of diabetic patients, you should answer in this way. It should be absolutely correct. And what else should be also controlled? Blood pressure. Blood pressure should become normal. What does it mean, normal? Please, you should revise normal value for blood pressure. It's better to have normal optimal blood pressure. No, maybe sometimes it's impossible for a patient, but not hypertension. It should be the purpose of your treatment and for administration of antihypertensive medications. Target level of blood pressure values. Now, please write down. It's very important to know, to remember. So, criteria for systolic should be less than 140 millimeter mercury, but more than 120. And if there is the presence of chronic renal failure, chronic renal disease, and the degree is A3, group A3, albuminuria, you should remember, 3. So the target value should be more strict, more than 120 and less or equal to 130. You should remember. Our purpose is not to decrease blood pressure less than 120 because to keep normal blood pressure, it's important for keeping of adequate glomerular filtration. And diastolic blood pressure should be less than 85 millimeter mercury and more than 70 millimeter mercury. Please, this table, this chart, this information is important. Please write down. I want you to have it. Non-drug methods of blood pressure correction. No, they're different. I'm sure that you know some of them. No, first of all, restriction of salt. Intake up to 3 grams per 24 hours. 3 grams. What does it mean? You should not use any extra salt during cooking. And only this measure will reduce blood pressure from 2 to 8 millimeter mercury. A healthy diet without fatty food, salty food, preserves, for example, it's also of great importance because cheese is also contains too much salt, etc. Decrease of body mass, it's very important. Decrease of body mass is indicated if BMI is more than 25 kilogram per meter square, and such decrease will lead to decrease of blood pressure, BP, from 5 to 20 millimeter mercury per 10 kilogram of weight decrease. It's very important to understand and to follow this recommendation. And non-drug methods of blood pressure correction. Usage of alcohol, not more than 30 grams a day for males, not more than 15 grams a day for females, and such measure will lead to weight decrease about 5 to 20 millimeter mercury per 10 kilogram. No, I'm sorry, 5 to 20 millimeter mercury. What about no stopping tobacco smoking? And blood pressure will be reduced from 2 to 6 millimeter mercury. Aerobic physical exercises, minimally from 30 to 40 minutes, 3 to 4 times a week, and it leads to decrease of blood pressure per 4 to 9 millimeter mercury. Major groups of antihypertensive preparations. No, I think that it's very clear for everybody because you are the advanced students, you are the 6-year students. The first group you can say is inhibitors. This group is of great importance. Angiotensin II receptors blockers, diuretics, such as thiazides, thiazide-like diuretics, indapamide, loop diuretics, aldosterone antagonists, calcium channels blockers, dihydropyridine or non-dihydropyridine preparations, beta-adrenal blockers, non-selective, beta-1, beta-2, cardioselective ones, beta-1, adrenal blockers, combined beta-1, beta-2, and alpha adrenal blockers. And there are also additional groups of antihypertensive drugs that can be helpful in the certain situations, such as alpha adrenal blockers, preparations of central action, alpha-2 receptors agonists such as clonidine, methyldopa, I2 imidazoline receptors agonists, moxanidine, ilmenidine, and direct renin inhibitors. This preparation drug is named as aliskiren. And optimal combinations of antihypertensive preparations are the following. We can combine ACE inhibitors and thiazide, ACE inhibitors and thiazide-like diuretic indapamide, it's named as indapamide, ACE inhibitors and calcium channels blockers, and antagonist of I'm sorry, antagonist of angiotensin 2 receptors blockers plus thiazide. Angiotensin 2 receptors blockers plus calcium channel blockers. Calcium channels blockers can be combined with thiazides. Calcium channel blockers can be combined with beta adrenal blockers. Nowadays, there are also triple combinations of antihypertensive preparations. What is well known for about AC inhibitors nowadays? And it's important for management of diabetic patients. Please listen to me attentively because you don't know this information. There is no negative effect on carbohydrate and lipid metabolism because AC inhibitors, they're neutral, metabolically neutral. And it's very important in this situation. Decrease of insulin resistance of peripheral tissues. Drugs of the first choice, they are drugs of the first choice in treatment of micro and macroalbuminuria. They take nephroprotective effect in patients with DMI 1, diabetes mellitus type 1 and diabetes mellitus type 2 in the both types of diabetes mellitus. They are the drugs of the first choice. AC inhibitors, examples. No, please, you're welcome. You should know all these drugs. Captopril. Captopril, I'd like to pay attention that it's short-acting drug, and if you want to manage a patient with captopril, you should administer this drug not less than twice or thrice, sometimes even 4 times a day. And the dosage should be different. Nowadays, captopril is assessed as a drug of the first choice on emergency. It can be very effective, especially if systolic blood pressure is less than 160 millimeter mercury. Enalapril in tablet. This drug is longer acting as antihypertensive drug. That's why it can be administered twice a day. Twice a day, not thrice or 4 times a day, but twice a day in different dosages. Of course, the usage of any antihypertensive drug should be started with a lower dosage, and this dosage should be titrated, so increased gradually under blood pressure control. Ramipril is the gold standard of long-acting AC inhibitor. It should be taken once a day. Fosinapril once a day. Lisinapril is very popular preparation in our country. I think that abroad as well because it's effective. Moaxipril once a day. Perindopril is very popular, especially in management of diabetic patient. Not only diabetic, all patients of arterial hypertension, but especially if you manage the patient with metabolic syndrome or diabetes mellitus. Perindopril can be combined with indapamide. It can be combined with any other antihypertensive drug, but commonly with indapamide. Angiotensin 2 receptors blockers, they are also metabolically neutral. They don't experience any negative effect on carbohydrate and lipid metabolism, and they decrease insulin resistance of peripheral tissues. They are also assessed as drugs of the first choice in treatment of micro and macroalbuminuria. They have also nephroprotective effect in patients with diabetes mellitus type 1 and diabetes mellitus type 2. And they experience also maximal ability to decrease the left ventricle hypertrophy. Please remember about this action. Angiotensin 2 receptors blockers and AC inhibitors, they can decrease left ventricle hypertrophy. It's important. They can stop progression of heart failure. angiotensin II receptors blockers. No, please, you can read and you can make photo, write. You should know losartan. Original drug is named as Cosar, and irbesartan. Original drug is named as Epravel. Telmisartan. Original drug is named as Mifardis. Telmisartan in combination with amlodipine. Original name of drug is Twinstar. Valsartan. Original name is Diavan, and Azilsartan. Original name is Edarbi. Edarbi, please make photo, or maybe it's better to write, but it's important to know about all these drugs. And what about contraindications for administration of AC inhibitors and angiotensin II receptors blockers? Hyperkalemia more than 6 millimole per liter, increase of serum creatinine level more than 30% of initial value in 2 weeks after administration. So it's very important to check potassium level and creatinine level. You should remember. You should understand why. And if there is bilateral stenosis of renal arteries, is assessed as counterindication for NC inhibitors and angiotensin II receptors blockers as well. The presence of pregnancy and lactation. Diuretics. They're also so popular as antihypertensive drugs because they can reduce the volume of circulation blood, and they're effective in volume-dependent arterial hypertension. I'd like to pay attention that nowadays we know that monotherapy by only diuretics is usually not effective or not effective enough. That's why it's better to use them in combination with other antihypertensive drugs, for example, ACE inhibitors or angiotensin II receptors blockers. Efficiency is higher in combination in ACE inhibitors and beta blockers. Thiazides should be used in rather low doses, 6.25, 12.5 milligram daily. In such doses, they don't induce essential metabolic disorders such as hyperglycemia, dyslipidemia, hyperkalemia, etc. And thiazide-like diuretic in dopamine retard is used in the dosage 1.5 milligram. Once a day, it's better to use it in the morning. Decrease risk of acute myocardial infarction, stroke. It was confirmed. They are contraindicated if glomerular filtration rate is less than 30 milliliter per minute. And loop diuretics are indicated in combination of diabetes mellitus and edema syndrome. So diuretics are of great importance. And beta blockers indicated in combination of diabetes mellitus and ischemic heart disease, heart failure, and post-infarction period. They can make the duration of patient's life longer. Ability to mask development of hypoglycemia, you should remember about it, and non-selective beta blockers such as propranolol, and in the low degree, selective beta blockers can increase development of insulin resistance and dyslipidemia. It's important to remember. And beta blockers with vasodilative features such as carvedilol, nebivolol, they improve values of carbohydrate and lipid metabolism, and they conduct nephroprotective effect. No, if you did not know this information before, no, please write down. I think that it will be beneficial in your future clinical practice. And what about beta blockers? Names. Non-selective propranolol, selective metoprolol, atenolol, bisoprolol. No, propranolol maybe it's not so popular in treatment of diabetic patient, but later we'll revise with you material about the treatment of thyrotoxicosis. Propranolol is used in treatment of arterial hypertension, and not only arterial hypertension, in the patients suffering from thyrotoxicosis due to Graves' disease. It's important to remember. Metoprolol, atenolol, bisoprolol. Bisoprolol is very popular in treatment of diabetes mellitus, especially if this patient also experiences ischemic heart disease features. Non-selective beta blockers and alpha-1 blockers with vasodilative characteristics. I'd like to pay attention to carvedilol. Daily dose should be not more than 50 milligram, and elderly not more than 25 milligram, and selective beta blockers with vasodilative characteristics. Nebivolol. In TEP, there are 5 milligram, daily dosage should be 2.5 or 5 or 10 milligram maximally once a day. It's very important to remember carvedilol should be administered twice a day. Alpha-adrenal blockers. They have favorable metabolic action. They're indicated in treatment of diabetes mellitus in combination with dyslipidemia. It's important to remember. They should be carefully used in diabetic autonomous neuropathy because they can provoke orthostatic hypertension. And they are contraindicated if there is heart failure in the patient, acute heart failure or chronic heart failure as well. Calcium channels blockers. In medium therapeutic doses, they are metabolically neutral. That's important. Short-acting calcium channel blockers, dihydropyridine, in medium and high dosages are contraindicated in diabetes mellitus and ischemic heart disease, especially if there is unstable angina, if there is acute myocardial infarction, if there is prominent heart failure. Please remember about it. Short-acting are counter-indicated. Long-acting calcium channel blockers, dihydropyridine, amlodipine in the dosage 5 or 10 milligram once a day. There is also lercanidipine, it's also long-acting in the dosage 10 or 20 milligram once a day, are rather safe in diabetes mellitus and ischemic heart disease. Though you should feel the difference. So long-acting is possible to use. Recommended combination of ACE inhibitors and beta blockers to approach target level of blood pressure and cardioprotective effect. Diseases of thyroid gland. Diseases of thyroid gland, you should remember that there are many diseases of thyroid, and there are the most important disorders. Graves' disease, for example. Graves' disease, according to its pathogenesis, is systemic autoimmune disease due to production of serum IgG antibodies to the thyroid TSH receptor, stimulating thyroid hormone production, became like TSH, and is manifested by diffuse goiter and clinical syndrome of thyrotoxicosis. Thyrotoxicosis is manifested by the presence of goiter. You can see the patient on this photo. On this photo, you can see a goiter as well. You can see exophthalmos, and such patients, and both patients, of course, they complain of palpitation, tachycardia, and dyspnea can occur in the patient because of the presence of heart failure, and blood pressure is increased. But which blood pressure is increased? Only systolic blood pressure. Systolic arterial hypertension plus tachycardia In severe case, atrial fibrillation is characteristic. There is high cardiac output initially. It produces abundant pulse, widened pulse pressure, loud cardiac sounds, and systolic murmur on auscultation. Thyrotoxic cardiac myopathy occurs. It's manifested by enlargement of the heart and symptoms and signs of heart failure. Arterial hypertension because of increase of systolic and drop of diastolic blood pressure. And on ECG, ECG is important to be recorded. There are very characteristic changes as high voltage at early stage, shortening of PR interval, sinus tachycardia. At the advanced stages, we can detect reduction of voltage, prolongation of QRS complex, non-specific changes of ST segment into wave, and in many patients there are signs of atrial fibrillation. Diagnosis should be confirmed biochemically. TSH level should be detected, it becomes low, and concentration of thyroid hormones, T4 free fraction, T3 also free fraction, and a titer of TSH receptors stimulating antibodies, the immunoglobulins of class G, is also increased. When we have made a diagnosis, we should treat the patient. No treating treating target is to reduce thyroid hormone synthesis with the usage of antithyroid drugs or thyroστatics. You should remember about imidazole derivatives, propyltiouracil is alternative group of drug. And what else is also used in treatment? Reducing of the amount of thyroid tissue. Surgeons can help us. They do nowadays total thyroidectomy. Nowadays, not subtotal, but usually commonly total thyroidectomy is used. Or if it's impossible to do surgery, radiation treatment or ablation with the usage of isotope of iodine 131 isotope of iodine or technetium can be effective enough. And how to treat arterial hypertension? You should remember that arterial hypertension should be treated with the usage of beta adrenal blockers. In this case, they are assessed as the drugs of the first choice. Now, first of all, of course, antithyroid drugs should be administered, propyltiouracil or derivatives of imidazole, carbimazole, or metimazole. And the next administration, beta blocker. Of course, if there are no counterindications for beta adrenal blockers. The absolute counterindication for beta adrenal blocker administration is bronchial asthma and the presence of bronchial obstruction, but especially bronchial asthma, because the usage intake even of one dosage of beta adrenal blocker can provoke asphyxia, severe bronchospasm and asphyxia, and the death of the patient. Please, you should remember about it. Значит, propranolol, it's non-selective beta adrenal blocker. It blocks beta 1 and beta 2 adrenal receptors. Is assessed as a drug of the first choice because such preparation is able not only to block adrenal receptors and to reduce the heart rate. It's important for a patient with thyrotoxicosis. It can reduce blood pressure as well, arterial blood pressure. But propranolol also inhibits deiodinase, or the enzyme deiodinase, and it suppresses the conversion of T4 thyroxine to more active, more potent thyroid hormone T3 triiodothyronine in peripheral tissues. And this action of non-selective beta-adrenal blocker is very beneficial in the case of thyrotoxicosis in Graves' disease. Well, sedatives are also used, but sedatives, of course, are assessed as additional drugs. Hypothyroidism, it's also a clinical syndrome, but it's also the name of a disease, and it's characterized by persistent decrease of influence of thyroid hormones to target tissues. Distribution is rather high, about 12%, mostly among elderly women. And there is depression of thyroid function due to different diseases. Pathogenesis is very important. I think that you know something you can read on this slide. You can see that there is a depression of metabolic rate, decrease of demands in oxygen, myxedema occurs due to accumulation of glycosaminoglycans, excess of vasopressin, and deficiency of ADH. Excess of vasopressin leads to the presence of edema, the appearance of edema, the increase of peripheral resistance of vessels, and the most typical clinical symptoms and signs are here on this slide: hypermetabolic syndrome, hypothermia, decrease of oxygen demands, overweight, obesity, decrease of appetite, hypercholesterolemia, hypertriglyceridemia. And how to treat this patient? You can see the photo of the patient with myxedema. She suffers from hypothyroidism. And what do you think about her heart rate? Heart rate is usually disordered. Bradycardia is usually characteristic. What about her blood pressure? Blood pressure can be increased, especially diastolic blood pressure. Systolic blood pressure can be normal. Sometimes it can be even decreased, but in many patients, I'd like to tell you true, you can also detect arterial hypertension, not only diastolic but also systolic. But diastolic blood pressure is mostly increased, is more increased than systolic. And such patients, they complain on dull pain in cardiac region, bradycardia enlarged, relative heart dullness, weak sounds on auscultation can be detected, arterial hypertension or sometimes hypertension, development and progression of atherosclerosis and atherosclerotic associated diseases. And in severe course of hypertension, in severe course of hypothyroidism, we can detect pericardial, pleural, or abdominal effusions. On ECG, low voltage, especially of PNT waves, long PR interval, AV conduction disorders, and other conduction abnormalities. Antihypertensive therapy for these patients. What drugs are the drugs? The first choice. EC inhibitors, you're welcome. In combination with diuretics, thiazides or indapamide, EC inhibitors in combination with calcium channels blockers, no, such choice is worse because calcium channel blockers, they can provoke extra edema. Angiotensin 2 receptors blockers in combination with thiazides, calcium channel blockers in combination with thiazides, such administration can be also effective. Adrenal disorders. You can see the photo of the patient with Cushing's syndrome. Cushing's syndrome, you can see that there is centripetal obesity. You can see moon face on the patient, blushing. You can see also stria on the skin of the abdomen of the patient. And such patients, they usually experience arterial hypertension because the excessive production of glucocorticoids and mineralocorticoids. And you remember that Cushing's syndrome is divided to central variant. This variant is named as Cushing's disease, and it's ACTH dependent hypercortisolism occurs in the patient because of stimulation by ACTH, the both adrenal cortices. And there is also adrenal hypercortisolism, or it's named as Cushing's syndrome, and it's caused by the occurrence of a tumor that produces glucocorticoids, cortisol, in high concentration. Such tumor is named as corticosteroma or glucosteroma, and Cushing's disease is usually associated, is caused by the presence of tumor in the anterior pituitary, and it's named as corticotropinoma. The third variant of Cushing's syndrome is named as iatrogenic or medicamental, and it occurs in the patient those had to intake glucocorticoids for rather a long period of time. No, maybe severe bronchial asthma, maybe lupus erythematosus, rheumatoid arthritis, etc. And secondary to ACTH, non-endocrine tumors such as bronchogenic carcinoma, carcinoid of thymus, pancreatic carcinoma, they can bronchial adenoma as well. They can produce also ACTH substances, ACTH-like substances. In such patients, they can experience symptoms and signs of Cushing's syndrome. Так, ну, all clinical manifestations are very characteristic, typical habitus, increased body weight, centripetal obesity, fatigability, weakness, hypertension is mostly diastolic. What about any other clinical manifestations? Ecchymosis, cutaneous stria, personality changes, proximal myopathy, edema, osteoporosis, hypertrophy of clitoris can be present. Diagnostics, you can see on this slide the methods those can confirm diagnosis. We have discussed this problem at the previous lecture. Laboratory findings are very important, and treatment. The most effective treatment of Cushing's syndrome is surgery. It can be excision of the tumor with the method of adrenalectomy on the affected site, or suppression of cortisol production with meta-10. Bilateral hyperplasia can be used in some cases, and if tumor is located in anterior pituitary, if there is Cushing's disease, this surgery should be neurosurgery, and access is transnasal, transsphenoidal access, and the name of surgery is adenomectomy. How to treat arterial hypertension in this case? It's very important to remember that all above mentioned antihypertensive preparations that can be used. ACE inhibitors, diuretics, angiotensin II receptors blockers, calcium channel blockers in combination with diuretics or thiazides or thiazide-like, diuretic indapamide, etc., etc. Beta adrenal blockers, especially if there are symptoms and signs of ischemic heart disease. And of course, these patients also require calcium, potassium-containing drugs. Pheochromocytoma. Pheochromocytoma produce and store and secrete catecholamines, and pheochromocytoma can be present in adrenal medulla, but may develop from chromatin cells in or about sympathetic ganglia, extraadrenal pheochromocytomas or paragangliomas. Clinical manifestations are different, but arterial hypertension is the most common manifestation. And what else is also characteristic for pheochromocytoma arterial hypertension? Rather high, not rather high, but high arterial hypertension and hypertensive crisis. hypertensive crisis. Crises can be frequent or sporadic, occurring at intervals as long as weeks or months, and with time, the paroxysm usually increase in frequency, duration, and severity. Sudden onset is characteristic. They last from a few minutes to several hours or longer. Symptoms are different: headache, profuse sweating, palpitations, apprehension. Pain in the chest or abdomen may be associated with nausea, etc. Так. We have to confirm diagnosis, of course, and we have also confirmed localization of the tumor with different methods. What about treatment? Значит, in preoperative management of the patient, we have to do induction of stable alpha-adrenergic blockade. So the drugs of the first choice are alpha-adrenal blockers. Before surgery, phenaxine benzamine should be administered for at least 10 to 14 days prior to surgery. Before adequate alpha-adrenergic blockade with phenaxine benzamine is achieved, paroxysm may be treated with oral doxazazine, 1 milligram once or twice times a day, or prazosin, 1 milligram twice or twice a day. And then you can administer beta adrenal blockers. In treatment of crisis, we should use also nitroprusside, calcium channel blocking agents, maybe angiotensin converting enzyme inhibitors, parenterally, intravenously. The most effective treatment of this pathology, of course, is surgery, and it's adrenalectomy on the affected site of bilateral surgery. After surgery, all patients will require replacement glucocorticosteroid and mineralocorticoid treatment. Radiation treatment is not effective, you should remember. Okay, and alpha adrenal blockers, you have to know these drugs, please. Aldosteronism, only a few words about this pathology. Aldosteronism is divided to primary. Aldosterone produces adrenal adenoma, is the cause of primary aldosteronism, or bilateral cortical nodular hyperplasia. And secondary aldosteronism, it's characterized by increased production of aldosterone in response to activation of renin-angiotensin system. And you can see that diastolic hypertension is characteristic because of increased sodium and extracellular volume, muscle weakness, fatigue because of potassium depletion, cardiac arrhythmias occurs very frequently, polyuria and polydipsia because of impairment of urinary concentrating ability. Laboratory findings are the following: hyperkalemia, hyponatremia, metabolic alkalosis, reduced serum magnesium. Treatment should include for primary aldosteronism, the most effective is surgical excision of the adenoma. Dietary sodium restriction should be used for the patient, and the administration of aldosterone antagonist. The name of this drug is spironolactone in the dosage from 25 to 100 milligram every 8 hours. And such treatment is effective in many cases. And of course, if there is idiopathic bilateral hyperplasia, spironolactone can be also used in the same dosage, but also every 8 hours. Surgery is indicated only when significant symptomatic hyperkalemia cannot be controlled with medical therapy by spironolactone, triamterene, or amiloride. Thank you for your attention and goodbye.
Нет, он к нам пришел,
Он, наверное, забыл.
и поздоровался, и потом ушел через 15 минут.
Ага,
Я
все.
выключили, да?
Да, и мне, если можно, флешку.
Да.
А он должен был мне